Hey guys, it's Andreas here, and welcome to my 3.5 hour study with me session. So before we begin, I just want to give you guys a little pep talk to motivate you guys to study. So a lot of people always ask me, hey Andreas, how come you don't take any breaks? Like, how can you just study 3.5 hours straight with no breaks? And my philosophy kind of falls in line with my study habits. So a lot of people always tell you you need balance in life, right? You need to stay like, you need to stay, keep it like this, right? You can't go like this or like this, 'cause that's too extreme. But I don't like the whole balance methodology in terms of if you stay balanced, that means you're doing everything half-assed, right? Meaning that if you stay in the middle, you're not really doing anything really that good. You're just staying right in between. But the way I do it, I do things extreme. So if you study and put all your effort into studying, right, and you go extreme like I do, take no breaks, you're gonna finish studying, right? The scale tilts like this, right? So that's extreme. There's no balance. But on the other hand, if you relax extreme in terms of like when you go to bed, no phones, you make sure you're in maximum comfort, that's also extreme, right? So at the end of the day, if you relax extremely and you study extremely, your life balances out, right? So if I were you guys, I would use these words of advice. Whatever you do, give it your all, because at the end of the day, everything balances out, all right? So enjoy the next 3.5 hours. Thank you. Now the QRS interval, what does that represent? The QRS interval represents what? Ventricular depolarization, right? Now that's what it represents. And then we have, so if you have the QRS interval, we have left bundle branch blocks, which we have WM, and then we have right bundle branch blocks, right? Now, when you look at your right bundle, if you have a left bundle branch block and you suspect a myocardial infarction, you're going to look at the Scarbosa criteria. Scarbosa criteria, you're looking for your, I think, ST segment depressions, or right in leads V1 to V3, right? Oh, good. Now when you have left bundle branch block in V1, lead 1, you're going to have it's going to look like this, so W-shaped. You're going to have a W-shaped QRS interval, and then in lead V6, right? V6, you're going to have a M-shaped, right? It's going to be the opposite for your P wave. Good. So here you have ST concordant. You have ST segment elevations, right? So ST segment elevations in one or more lead, and then ST segment elevations in V1 to V3. Good. Now let's look at these examples. So we have left bundle branch blocks here. Going to V6, right? This is going to be we have a left bundle branch block. V1, you're going to have something like that, right? And then V6, you're going to have M-shaped. Something weird. Good. Okay. Now endocarditis, 67, 69. What is this one? And what causes endocarditis? Endocarditis is going to be infection. It can be infectious or non-infectious inflammation over the inner layer of the heart that covers the valves. It can be infectious or non-infectious. What do we have here? So signs of DVT. So I know you're going to have Hoffman sign, right? The Hoffman sign is that when you lift when you have passive dorsiflexion, you're going to have pain in the calf, you're not have pain in the calf, you're going to have swelling in the calf, right? You might have some sort of purplish, sign, right? And then for DVT, we're going to have the Welsh criteria, right? We're going to have your Welsh criteria, which is going to be that's what's going to be, it's going to be PMH, I think, PMH, right? Which this is going to be these are the signs, right? The Hoffman sign, Sargosa, right? So blues, right? Unilateral calcium, renus, dorsiflexion, and then phlegma. Good. Now, what is a DVT? A DVT is going to be a clot usually in the calf, right? The lower extremities. And risk factors include PMH, right? Which then risk factors include what? If you have if you're immobile for more than 3 days, bedridden, I think it's going to be virtuous triad, right? I think it's virtuous triad, which is right. So if you're immobile, right? If you have signs of DVT or pulmonary embolism, right? History of pulmonary embolism or history of DVTs, immobile. If you're going to be if you have tachycardia, if you have malignancy, if you have if you have your what else do we have? Yeah, so Welsh criteria is that what you're going to have here includes you're going to be mobile, right? Good. What are the signs? Well, I think it's Welsh criteria, so clot. So you're going to have virtuous triad, which is venous stasis, which is going to be venous stasis, right? Which we see that it's going to be so virtuous triad, so you're going to have venous stasis, which is going to be long flights, right? Immobile, bedridden. You're going to have some sort of endothelial damage, such as your recent surgery, catheterization. Just see that. Yeah, so here it's going to be virtuous triad, so venous stasis, right? Venous stasis, which includes some sort of immobile, right? Immobile. Venous stasis, right? Immobile, bedridden, some sort of trauma, endothelial damage, such as like trauma, like recent surgery, which trauma includes so venous stasis, like long flights, immobile, bedridden, right? Endothelial damage, such as surgery, slow extremities trauma, and then also you're gonna have hypercoagulative state, like your pregnancy, thromboembolism, thrombophilia, pregnancy, or constitutive hyperhomocystinemia. Good. Now, good. Okay. Now, when you have your hypertrophic cardiomyopathy, this is going to be a diastolic cardiomyopathy. It's going to be systolic hypertrophy, there's going to be diastolic dysfunction. Differences between your hypertrophic cardiomyopathy is that you're going to have, so in addition to your hypertrophy of your asymmetrical hypertrophy intraventricular septum, you're going to have a left ventricular left ventricular outflow obstruction, which is going to lead you to reduction in your cardiac output. Cardiac output. Now, cause it can be genetic, autosomal dominant. Then it's going to be autosomal dominant. That's going to be cause, or it can be autosomal dominant cause. It's genetic. Okay, good. Additional, which is okay, good obstruction. Now, chronic heart failure. So when you have chronic heart failure, so chronic heart failure is just going to be congestive. Now, when you have chronic heart failure, the first line treatment, acute heart failure, right, depends on the type. But you're always going to put it on a. So first line treatment always is going to be lifestyle modifications, right? And then you also want to put them on an aspirin, right, or acetylsalicylic acid to reduce mortality. And then the first line treatment always going to be, so you have heart failure with your ejection fraction, and the heart failure for the ejection fraction. Got it? Now, first line treatment always lifestyle modifications, right? So what reduces risk heart failure for reduced ejection fraction? So you're going to have your beta blockers, that's one. Your ACE inhibitors, your angiotensin receptor blockers, your hydralazine, right? What else? Hydralazine, your isohydralazine, isosorbide, hydralazine, isosorbide, right? You're going to also have your sodium glucose SGLT2 inhibitors, right? For both preserve, it's going to be your dapagliflozin, empagliflozin. Good. Dapagliflozin, got it. What else do you have? Dapagliflozin. What else? Come on, keep going. We have empagliflozin. Then you're also going to have your hydralazine. Then we're going to have your beta blockers, hydralazine, your calcium channel blockers do not reduce mortality, increase risk, right? You can do your implantable cardiac pacemaker, then preserved, and then now has reduced, so symptomatic is going to be your diuretics, right? Your loop diuretics. Also your beta blockers, right? And then your loop diuretics, right? Your passage spironolactone, eplerenone, low-dose spironolactone, hydralazine, sorbide dinitrate, and implantable defibrillators, right? Mortality. Then dapagliflozin, okay, good. And then just so you know, loop diuretics and digoxin are for symptomatic relief only. Good. So you have your loop diuretics, right? Plus your digoxin are going to be symptomatic relief only, and no mortality benefits. Good. And then reduced hospitalization is going to be your loop diuretics. Your loop diuretics, right? Oh, no, your digoxin. Good. Now, first line, you're always going to be lifestyle modifications, right? So this is going to be limit dietary sodium and fluid intake. Good exercise. Right? Now, reduce mortality for reduced ejection beta blocker, inhibitor, intensive receptor blockers, isosorbide nitrate, hydralazine, isosorbide nitrate, implantable cardiac defibrillators, your low dose spironolactone, eplerenone, fasciculus, and remember your sodium glucose transporter 2 inhibitors, which you end up and then calcium channel blockers may increase mortality. Now, okay, good. And then which else is your loop diuretics, right? Is for digoxin. Okay, what happens here? Now, dyslipidemia. So we have risk factors. Anything that, okay, good. Now, dyslipidemia, is that you're going to have elevated lipids, LDL. So you have low, high LDLs, right? High density proteins. Elevated cholesterol, elevated triglycerides, right? Good. Then screening. So your lipid levels. So at age 35 you should do lipid levels, right? Every 5 years, right? So if you're 35, you start at age 20 if you smoke, all right, right? And any sort of, good. So, good. So best initial test, right, is going to be lipid and then causes. Anything that causes, diagnosis and all that, right? So anything that causes. So secondary, so cholesterol, yeah. Now primary dyslipidemia, it can be genetic predisposition, it can be familial, right? It can be familial, or it can be secondary causes, right? The secondary causes can be diabetes mellitus, or hypothyroidism, hypothyroidism, stuff like that. Now, most significant, most patients have no specific symptoms, right? Now, patients with extremely high triglycerides, right, and LDL levels, right, may xanthomas. You have 10 xanthomas, rubber nodules, xanthoma, and lipid retinals, right? Rest over 100. Pancreatitis, good. Hyperlipidemias, right? Primary hyperlipidemias, good. Now, so most patients are going to be, so if you have really elevated levels of triglycerides and LDLs, you have the symptoms of like familial, like xanthomas, xanthalmas, right? Lipid retinalis, and coronary, right? Patients with really high triglycerides over 500, pancreatitis, good. Now, okay. Now, indications for testing. So, if you have testing, it's going to be screening all patients that are above, or are those 20 years old with increased factors for atherosclerotic cardiovascular disease, repeat every 5 years. Additionally, all smokers, right, all smokers of all ages should be screened for dyslipidemias. Can increase risk. Good. Now, this is going to be screening. That's going to be screening. This is going to be your atherosclerotic coronary vascular disease is your 10-year risk factor, 10-year risk for developing atherosclerotic cardiovascular disease in the pool equation, right? Now, individuals, if you have your LDLs over 190 or triglycerides over 800 or 500 or greater, and signs of like familial and like signs of atherosclerotic examples and all that, look for genetic causes. Good. Now, when you can best hear. So when you can best hear murmurs, right? Remember, you have so right-sided, right? Inspiration, left-sided, on expiration, right? And we have these over here. Let's go over these real quick. So page 24. So we have all these. So first one we're going to have is, remember, when you increase preload, you reduce the intensity of your HOCM, right? And also you increase the, your mitral valve prolapse, right? But your mitral regurgitation, regurgitation, and stenosis increases, and your trickles defect, right? Good, right? Good. Now, okay, good. Now, inspiration, good. Now, okay. Now, when you have your so this one, right? When you have your hand grip maneuver, which is going to increase increases your preload, right? Hand grip maneuver, which increases your semi-vascular resistance, which is your preload and afterload. So preload and afterload, right? This can reduce your HOCM, right? Reduces the mitral valve prolapse, and also reduce the aortic stenosis, but increases the fluidity, right? Now, when you have your when you decrease your preload, when you do your valsalva maneuver, when you strain it, or or what else? Where you're standing, right? Strain, you're going to reduce your preload, reduce your semi-vascular resistance. Reduce semi-vascular resistance, right? Increase your HOCM, increase your mitral valve prolapse, right? And prolapse, increase prolongability, so prolong earlier click, right? It reduces your aortic stenosis, reduces your regurgitation, defect, right? Now, when you do your increase your preload, increase your semi-vascular resistance, you're going to turn via your passive leg raises, your squatting or relaxed Valsalva. You're reducing your mitral valve prolapse, reducing HOCM, right? Increasing your good. So more blood. So when you increase more blood, increases venous return, which increases preload, right? Which increases all members, etc. Good. Okay. Now, when you have acute coronary syndrome, now ACS, acute coronary syndrome, that's going to be including, so it's going to include your NSTEMI, right, and your unstable angina, right? And the best test for this one, depending on what it is here, is that you're going to do your ECG, which is going to show you elevations, right, and also require biomarkers. Good. ECG, and then good. Now, go to table 1, page 33. Now, what is this one? How to manage. So let's go over these arrhythmias and all that. So when you have your first one right here, if you have your pulseless electrical, so you have your pulseless electrical activity, asystole, and pulseless electrical activity. First thing you want to do is cardiopulmonary resuscitation, CPR, right? Then you want to give epinephrine or vasopressin. Then understand which are the 5 H's and 5 T's, right? 5 H's is hypokalemia, hyperkalemia, right? Hypothermia. What else? Acidosis, right? You can be hypertensive. You might be hypotensive, right? Hypotensive. hyperlipidemia, hypothermia, and also you can have your hypovolemic, hypoxic. So hypovolemic, hypoxic, acidosis, hypothermic, and T's you use tablets from overdose, right? You can do your, what else you can have? You can have your cardiac tamponade, you can have your thrombosis, pulmonary embolism, or your arterial embolism, right? Or you can have your tension pneumothorax. Good. What's next? Now, when you have we have a bunch of them. When you have your ventricular fibrillation or your ventricular tachycardia, without pulses, ventricular tachycardia, ventricular fibrillation, also ventricular tachycardia, what do you do over here? So if you're unstable here, you're going to have your desynchronized cardioversion, right? Desynchronized cardioversion. If you're stable, what do you do? If you're stable, first thing you want to do here is a little different. So the first thing you want to do here is administer CPR, cardiopulmonary resuscitation, right? And after that, you want to do unsynchronized defibrillator, right? And then another 5 rounds, CPR, and then unsynchronized defibrillator, another 5 rounds CPR, and then you're going to have your adenosine, right? Epinephrine. So initiate, and then defibrillate immediately, defibrillate again, epinephrine, and then 5 rounds CPR, unsynchronized defibrillation, adenosine, and then amiodarone, right? 5 rounds, and then 5 rounds, and then epinephrine. Good. Now, when you have your supraventricular tachycardia, which includes your atrioventricular tachycardia, atrioventricular tachycardia, includes your Parkinson's syndrome, and also includes your multifocal tachycardia, right? What you do here, if you're stable, you're going to do your unstable, your synchronized cardioversion, right? Which is okay. And then if you're unstable, if you're stable here, first thing you want to do is try to do some sort of vagal maneuvers or vagal maneuvers, scope or curve massage, right? Put it back, right? That first you can give them adenosine, right? If adenosine, it really gets worse with Parkinson's syndrome. That's the one with calcium channel blockers. You lock it out of here. But yeah, good. Now, if you have your atrial systole, your atrial flutters, or your atrial flutters, right? Or your atrial fibrillation, right? Atrial fibrillation flutters. If you're unstable here, you're going to do your synchronized cardioversion, of course. If you're stable, now listen, if it's less than 48 hours, less than 40 hours here, what you want to do here is that you want to do your, you put them on a rate control, beta blockers or calcium channel blockers, right? And then you want to put them on, you want to do a echocardiogram, right? Right. Now, if you're going to have someone who has, if you're greater than 40 hours, calcium channel blockers, beta blockers, right? Plus your anticoagulants for at least 3 weeks, or you can do a transesophageal echocardiogram to left atrial thrombus, right? And then you have to do left atrial thrombus before you can do your synchronized cardioversion. Got it. And then synchronized cardioversion. And then after that, 4 weeks of 4 weeks of anticoagulants, right? So if you're less than 40 hours and you're stable, yeah. So stable control rate, and then 48 hours electrical cardioversion. So electrical cardioversion, if it's less than 48 hours, right? Otherwise, commission must rule out. Yeah, good. Now, you have atropine and maybe some sort of symptomatic atropine. I think temporary cardiac pacemaking. Good. So again, if it's less than 48 hours, you give them your beta blockers and your calcium channel blockers, right? Which is rate control, and then you can do electrical cardioversion in less than 48 hours. Good. Now, what is DVT? So deep vein thrombosis is the clot in the lower extremities. Risk factors are going to be virtual triad, right? Where you're going to have venous stasis, which is going to be your immobile, traveling for a long time, more than 3 days, or like bedridden, right? And then you're going to have some sort of trauma, like any sort of surgery, catheter placement, right? Or you can have some sort of like trauma, or like and then hyperactive state, like contraceptive use, malignancy, pregnancy, something like that, or thrombophilia, something like that. Good. Now, when you have your tachycardia, the most common cause of tachycardia is going to be your what? Okay, we have these causes, right? What can be the causes? It can be your reentry circuits, right? It can be your increased automaticity, and also it can lead to your trigger reactivity, right? Trigger reactivity. Now, normal automaticity. The normal automaticity is where is a multifocal atrial tachycardia is where tissue that in the heart and the atrium, right? And it was usually not really part of maintaining rhythm. It's going to start helping, right? And then when you have your triggered activity, is that after your cardiac catchment potential, you're going to have the after depolarization, which are going to hit threshold and fire action potentials, right? You're going to see this in your then we have reentry circuits, right? With the most common type, it's just going to be anterior intake, good. This is going to be torsade points, right? Good. So increase automaticity, okay, good. Multiple check, good. Okay, now what is over here? So when you have chronic heart failure, right, with cardiac progression. Now, okay, so the most lifestyle medications inhibit your limit your sodium intake and limit your food intake, right, and diet and exercise, right. Now, which drugs are going to reduce mortality for your heart failure, reduce checkpoint? So systolic is going to be, you're going to have your ACE inhibitors, you're going to have your angiotensin receptor blockers, you're going to have your beta blockers, right. You're going to have your isosorbitol hydralazine dinitrate. You're going to have your implantable cardiac defibrillator. You're also going to have your low-dose spironolactone and epinephrine, right? Potassium channel blockers, right? And you're also going to have your sodium glucose transporter 2 inhibitors, dapagliflozin, epagliflozin. Good. And that's going to be the same thing for your preservative corrections. Now, drugs that only preventatively gives me your loop diuretics and your digoxin. Digoxin actually going to reduce mortality. Good. Now we have one more to mention. You're going to have, okay, good. Now aortic dissection. Remember, you're going to have aortic dissection versus your aortic dissection versus your aortic aneurysm, right? Aneurysm is going to be a bulging, right? Now, in aortic dissection, I believe here is that this can be caused by what aortic dissection versus your aortic aneurysm. You can have your you can have your abdominal aortic aneurysm, or you can have your thoracic aortic aneurysm, right? I think in your aortic dissection, this can be caused by hypertension, in which this presentation is that you're going to have anuria, so you're not going to be peeing. You're going to have paraplegia, paralysis of your legs, and you're going to have different, pulses in your right and your left arm, right? Good. So dental tear. See that? So then you're going to have ruptures. You're going to have a sudden anterior chest pain. It's going to radiate to the medius scapula. Good. Now name the systolic and diastolic. Okay, good. Now we have systolic and diastolic. So systolic, remember, is going to be what? Then diastolic is going to be what? Diastolic, the arms, pits, right? So aortic regurgitation, mitral stenosis. Then it's going to be arms. Then it's going to be your pulmonary insufficiency, your tricuspid stenosis as well. Then the systolic members are going to be your aortic. You're going to be mitral valve prolapse, mitral stenosis, tricuspid stenosis. Mitral stenosis, mitral regurgitation, tricuspid regurgitation, ventricular septal defect, aortic stenosis, right, mitral prolapse, mitral regurgitation, tricuspid regurgitation, don't forget that. Good. So then we have, good, now it is. So we have aortic stenosis, good. Now aortic stenosis, right? This is going to be your so between S1 and S2. This is going to be your systolic, crescendo, decrescendo, ejection, murmur. Best heard since the aortic. Best heard at the right second intercostal space. For the right second intercostal space, right? It's going to radiate to the carotids, right? Radiate to the carotids, right? Then you're going to have your mitral regurgitation and your mitral regurgitation and your tricuspid regurgitation, right? Now, this best heard at the mitral valve, so at the left mid-clavicular fourth intercostal space. This is going to hurt the fourth substernal left tricuspid, fourth intercostal space, right? And your mitral regurgitation is going to be this can do with whole systolic murmurs, right? But the mitral regurgitation is going to radiate to the axilla, right? Good. And then you have your mitral valve prolapse, right? And mitral valve prolapse. This is going to be a mid to late systolic murmur, systolic murmur, right? With a mid-systolic click, has a mid-systolic click, right? So especially at the apex, right? With a preceding click, right? Due to the mitral valve prolapse, right? And then you have your ventricular septal defect, right? Ventricular septal defect is going to be a whole systolic murmur, so it's going to be a mid to late systolic crescendo murmur, right? And then you have your whole systolic ventricular septal defect, which is going to be the greater the murmur, the lower the intensity, right? So that's what the best word is tricuspid space. Good. That's where the good. That's what tricuspid area. You're going to have your aortic regurgitation. Regurgitation is going to be your diastolic, decrescendo, blowing murmur, high pitched blowing murmur, early diastolic, right? Professor D got, right? And then okay, you're gonna have your mitral stenosis, which is gonna be your late diastolic diastolic murmur, rumbling murmur, followed by an opening snap, followed by a opening snap. The duration of the murmur for this intensity, right? Good. Also called erratic fever. And then you have this continuous so good. Okay, now dyslipidemia. Now remember, if you have your primary cause, which can be familial hyperdyslipidemia, and secondary causes can be like hypertension, can be a lot of things that can cause hypertension, smoking, hypothyroidism, or have that disease, right? Now, so most of these pneumatic, but if you have symptoms of what? If you have very high levels of triglycerides and very high levels of cholesterol, right? You can have your LDLs and triglycerides. You can have tendon xanthoma, xanthosmas, lipid analysis, and cornealiscus status. And then patients who have really high levels of triglycerides over 500 can have pancreatitis. Good. Now, diagnosis here. So when you do the best initial testing, is going to be a lipid panel, right? This is screening over 35 years old, screening every 5 years. Anyone who over 20 years old with a ASVD risk has to be tested every 5 years. On all ages with smoking should begin testing every 5 years, right? All patients who smoke. Good. Depreciation, you have your 10-year ASVD, which is the risk factor for getting your atherosclerotic cardiovascular disease. We need a Pool's equation. Now, individual treatment, if you have high LDLs over 190, triglycerides over 500, and some sort of like tendon xanthomas or cornealiscus, just for familiar primary causes. Good. Now, how to diagnose. So, we have your, so that's the nuance and all how to diagnose CCG. With ECG, you're going to localize it based off your ST segment elevations, right? ST segment elevations, right, I guess, right? And then, my version, coding enzymes, you're going to use, you're going to have your CKMB. Remember, you're going to have your troponin is more specific, your CKMB is more for reinfarctions. Good. Now, troponin level is going to peak within 24 hours, and then 24 to 48 hours. Good. Yeah, 24 within 40 hours, right? You see that? So troponin levels peak within 24 to 48 hours, while CKMB is within 24 hours. Good. So remember Sorgo's criteria. If you have a left bundle branch block and the presence of myocardial freeze with myocardial infarction, ST segment elevations and one related depression. What's more sensitive, specific? Is for reinfarction, right? 24 to 48 hours. Good. Now, aortic dissection. Aortic dissection is going to be the one where you have the it's going to rupture, right? You have the tearing. You're going to have the sudden tearing pain in the anterior chest, which is right between the scapula. Now, what is this? It's going to be aortic dissection. Is that it's going to be a luminal tear in the aorta, which is caused by hypertension, right? Associated with your hypertension, mitral prolapse, right? And also your Marfan syndrome as well, and then causes it's going to be hypertension, right? So it's tear. It's will tear. Longitudinal tear. That creates false lumen. Marfan's, right? So longitudinal tear. Longitudinal tear creates false lumen. Longitudinal tear creates false lumen, right? Now we have these x-axis deviations. What are this? This is plus 90 over here, which is going to be right. So your 0, it's going to be negative 30, which is going to be this is your AVF, right? This is going to be your AVL, right? And then over here is the lead wall. This is going to be negative plus 60, 120, right? 3, 2, and then it's going to be lead one over here, right? Axis between this is going to be your normal axis, going to be between negative 30 and 90, right? Now between negative 9, between your negative 90, and it's going to be your left hand here. This is going to be your left axis deviation, right, which is going to be away from lead one. So it's going to be actually away from lead one, from AVF, and towards lead one, and towards AVF, right? And then so AVL, and then normal, good. It's going to be away from towards lead one, right? Towards lead one. And then your right axis is going to be between 1 plus 180, right, and 90, right? So it's going to be towards lead 3 and towards AVF, right? And then you're going to have your extreme axis, 90 and 120, right? So it's away from lead 2, away from AVF. Good. Now, restrictive cardiomyopathies, right? Now, restrictive cardiomyopathy, this can either be a diastolic dysfunction, right? So you're going to have further depression, right? But you're going to have like recurrent scarring, or you're going to have loss of elasticity, right? Loss of elasticity. Now, causes of restrictive cardiomyopathy, right here, is going to be, give me your please help, right? So you're going to have your, these help, right? Hemochromatosis, right? You're going to have your sarcoidosis, your amyloidosis, right? You're going to have amyloidosis. You're going to have your lawful endocarditis, which is going to be eosinophilic infiltration of the heart, hypereosinophilia. You're going to have your post-radiation fibrosis, and your endocardial fibrosis, which is going to be in children. You're going to have fibrosis of the endocardium. Good. Now, signs and symptoms, it's going to be usually, remember in all these, you're always going to do a echocardiogram is going to be diagnostic, and then other tests you can do here is that you can just do a ECG, right? A low voltage ECG is going to prove it. And you're going to show amyloidosis, right? And those tests you can do the biopsy, those infiltrations, and then symptom signs usually asymptomatic. So you're going to have signs of right side heart failure. Good. So please post-radiation fibrosis, cardiofibrosis, okay? Right, echocardiogram, and then cardiac, okay, good, amyloidosis, good. Now you're gonna have signs of right-sided heart failure, your dyspnea, good. Now, sinus rhythm is normal rhythm, right? So sinus rhythm, that's gonna be normal. It's characterized by an upright, so QRS wave with preceding P waves, and upright QRS in V1 to V3, and then in EVL, so in V2, in V3, in your AVF, and QRS upside down in your EVL, good. How to calculate, so we have the boxes, one box is 300, two boxes 150, 100, here's a, okay, 100, here's a 5, try 100, then we have 75, 60, 50, good. Good, 1600, here's the EVF, and then QRS, good. Upright P waves. Good. Now, what do you see on chest X-ray for systolic heart failure? So on chest X-ray for systolic heart failure, you can see A, B, C, D, F, right? A, B, C, D, E, right? So you're going to have your alveolar edema, right? So alveolar edema. You're going to have your Kearney B lines, which is right. You're going to have your cardiomegaly. You're going to have your effusion, right? Pulmonary effusion. You're going to have your dilated. All right, good. Alveolar edema, you're going to have your Kearney B lines, which is going to be, okay, interstitial edema, right? Systolic, cardiomegaly, dilated upper lungs and infusion. Good. Now, what defines dyslipidemia is that you're going to have elevated lipid panel, elevated LDLs, reduced HDLs, right? It's the LDLCs, right? And then risk factors is anything, be familiar, right? Anything atherosclerosis. Good. Now, remember, tachycardia is the most common cause. You're going to have increased automaticity, right? You're going to have re-increased tachycardia, the most common. Also, you're going to have your automatic trigger activity. Good. Now, what happens over here? So, what does the ECG axis represent, right? So, the EKG. Now, what does it represent? The axis, so it's going to be the direction of the ventricular depolarization. Direction of the ventricular depolarization, right? You calculate by looking at the QRS, right? And leads 1 to AVF. Good. Now, what's the long-term? So STEMI, right? Long-term management using bananas, right? So you're gonna have your beta blockers, right? You're gonna have your aspirin, acetylsalicylic acid to reduce mortality, nitrates, right, to reduce ischemia. You're gonna have your high density statins to reduce lipids, and also you're gonna have your so we have your aspirins, right? And I'm also gonna have your right? Your beta blockers, right? Your acetylsalic acid to reduce mortality, your nitrates, your good. Then after that, if you do your percutaneous intervention, right? And then if you have your good, then that's percutaneous intervention, which is for your STEMI, of course, right? For your STEMI, what happens here? And if it's going to be like a regular bare metal, right, you're going to have for 3 months. But if it's going to be for if you're drug eluting for 12 months, you're going to be on your anticoagulant. You're going to be on this anticoagulant, right? Good, and then good, and then we have your aspirin. Remember, don't forget these numbers, right? So So it's going to be dual antiplatelet therapy, right? Which is going to be your B112 inhibitor, which is going to be your prosuber ticagrelor, prosuber ticagrelor. Then if bare metal stent, it's going to be greater than 30 days, right? Then if drug-eluting stent in place, good. Now what is this one? Now DVTs, right? We're going to have your SHIT PMH. Now like good VH SHIT PMH, so it's either going to be 0, right, and 1, right? 3 is very likely, and 1 and 2 is intermediate, right? Don't even do anything, right? So SHIT PMH here. So SHIT is going to be signs of DVT, signs of pulmonary history, DVT pulmonary, right? Immobility, if you're tachycardic, if you have any sort of hematopsis, right? Malignancies and post-operation, right? Now these are going to be point values. Are going to be 1.5, so three signs. So 3, 1.5, 1.5. So 3, 1.5, 1.5, 1.5, and then these are going to be 1, right? Good. Now signs is going to be your SHIT PMH. Well, so what's right here? SHIT PMH. Good. 3 or more, right? So if you have don't check, right? So 3 go right to ultrasound, and then here you're in Dopplers. Good. SHIT PMH 1.5. Good. So you got post-operation. Good. Now cardiomyopathy. So which ones? So we have cardiomyopathy, right? We have your dilated cardiomyopathy is going to be systolic, restrictive, and your hypertrophic going to be diastolic. Good. Now go over differentials, right? So then initial test for is always going to be echocardiograms. Good. What do you think about these? Right? So major abnormality in your, so you're dilated. We have your dilated, hypertrophic, and restricted, right? So major abnormality in diastasis is systolic, diastolic, right? So it's going to be problem with ventricular contraction, right? And impaired contractility. This is going to be a diastolic is going to be your then. So you have your dilated cardiomyopathy, right? And then your hypertrophic is going to be the restricted mean loss of elasticity, right? And it's going to be a problem with relaxation, right? Then when you look at your left ventricular, the cavity and diastole, the cavity size, right? Cavity size. So problem with contraction, right? It's going to be increase in diastole because you're going to reduce respiration, right? So it's going to be then it's going to be reduce good. And cavity size and systole, also the contraction. So and systole, right? If you're not contraction, it's going to be increasing, right? It's going to be increasing, decrease. Ejection fraction, you reduce the same wall thickness. In your dilated cardiomyopathy, that kind of increase, right? Increase restrictive, good. Good. Okay, now post-myocardial infarction. Let's go to the timeline, right? So we have 1 to 4 days, right? Then we have 5 days to 2 weeks, and then we have 1 day, right? Then we have 2 to 4 days, 5 days, 2 weeks. Good. Now the first day, what do we see over here? First day here, you can have something known as the other thing you get ventricular arrhythmias, right? Ventricular arrhythmias, right? Namely your ventricular tachycardia can be cause of death. That can be the cause of death. Right? And 2 days later, you can have your post pericarditis, right? You can have your good. And here you treat it. Avoid NSAIDs, right? You can show ventricular arrhythmias, avoid NSAIDs. Good. Avoid NSAIDs. See that? So like that, yes, ventricular fibrillation, ventricular tachycarditis. Good. And then still you have the thing, and you have pericarditis, which is going to be your pericarditis, right? Pericarditis, and then avoid NSAIDs because increased risk for ventricular fibrillation. Good. Now, how to diagnose someone with a SOSTEMI, right? So ECG, then according to that, right? So remember, so here we're looking for your central elevations, right? Then if you suspect, if you have a lot of version, right? See elevations and more lead. Let's say 1 to 3. And cardiac enzymes you're looking for. Remember, cardiac troponin is more specific and sensitive. It's used for infarctions, right? Now these are going to show within 24 to 48 hours. Within 24 hours, you're going to see KV peak. Good. Now, so treatment of DVT. So how do you treat DVT? You can do your subcutaneous low molecular weight heparin. We can do your oral direct oral anticoagulant. You read rivaroxaban, epoxaban, abivaxan, or dabigatran. Then you can do your abigatran, right? Or you can do your oral warfarin. Then in any case, you're going to do your or you do heparin plus oral heparin, and then plus 3 months of warfarin.
interfering. Good. See that? So you can start getting a little bit right, nice alarm. Like, okay. And then use all for 3 months. Good. Okay. Now, secondary hypertension, cardiovascular, it can be CAP, right? It can be your so first off, you can have is going to be your preeclampsia, eclamptic, right? It can also be you can also have your aortic stenosis, right? And also you can have is that aortic irritation, right? Also you can have your coarctation of the aorta. The coarctation of the aorta in children, you're going to have your cold. You're going to have cold upper extremities, right? Lower extremity with weak pulse. No, you're going to have your cold lower extremities, about 5 more delay, and then you have rheumatology in adults, right? And you're going to have your strong upper extremity pulses. Good. And then so quarter. So sleep apnea, hypoxia, and secondary hypertension. Good. So I think are you confused? So hypertension in the upper extremities, lower extremities, we're good. Your chest X-ray, hypoxia. Good. Now weeks 2. So remember, so when you have your, so we have this, right? Don't forget here. So post-myocardial infarction. So one day you can have very-threatening arrhythmias. You can have ventricular fibrillation, right? And then so 2 to 4 days, right? You still have very-threatening ventricular, but you can have your post pericarditis, right? Your peri-infarction pericarditis, which here right? Which here you avoid NSAIDs, left ventricular free rupture, because you're gonna have a increased risk of ventricular free rupture, right? And then 3 to 5 days later, 5 days to 2 weeks later, what can you have? You can have your left ventricular free rupture due to your cardiac tamponade, right? Acute pericardial tamponade. You can have, what else can you have? You can also have your papillary muscle rupture leading to pulmonary edema, life-threatening pulmonary edema, and mitral prolapse, mitral regurgitation, right? And you can have your septal rupture, left sternal border, which increase your right ventricle rupture. Okay, good. And then week 4. So weeks a month later, you can still have your ventricular aneurysm, right? Stressor syndrome, which is going to be autoimmune, which is going to be you're going to have the pulmonary edema, right? You're going to have a fever. You have elevated sedimentation rate, and treat with NSAIDs, like your peri-infarction pericarditis, and also you're going to have your so pulmonary edema, right? Fever. Okay, good. And then increased white blood cell. Okay, right, good. And then also you can still have your ventricular aneurysms. Good. Ventricular aneurysms and transformation. So fever, pericarditis. Because risk ESR inside the pericarditis, right? So stressor syndrome. Stressor syndrome. So you can have autoimmune fever, pericarditis. Good. Now, what are some? So, what quantificates end organ damage? We have all these, right? Now, nitroprusside. So, how does nitroprusside work when it comes to your, I think hypertension, right? So, nitroprusside and your phenyldopan, right? So, nitroprusside, right? Versus your nitroglycerin. Nitroprusside is going to reduce your, produces preload and reduces afterload. Nitroglycerin, right? Nitroglycerin only uses preload because of venodilate or arteriodilate, right? To activate your GCMP, increase nitric oxide, cause vasodilator, reduce blood pressure, right? And then while your phenyldopan, what that's going to do, which is D1 agonist, that's going to increase your renal blood flow, which is the increased excretion of water, and increase sodium as well, and reduce blood pressure that way. Good. Adverse effects, you're going to have headaches, right? So look for headaches. So increased nitric oxide, remember, that's what you reduce blood pressure. The prolonged use of cyanide poisoning, so ultimate status, hypoxia, you treat it with your sodium hydroxycobalamin, right? Hydroxycobalamin and sodium thiosulfate. Hydroxycobalamin and sodium thiosulfate, right? That's a perfusion and increase the sodium, right? So again, you can have your cyanide poisoning, ultimate status, hypoxia. Good. Now, what do you see on chest X-ray? For ABCD, right? So you can have alveolar edema, which good, alveolar edema, right? You're going to have your cranial B lines, which is going to be pleural effusion. ABCD, C, cardiomyopathy. You're going to have your dilated lungs, upper lobe lungs, and you're going to have effusion. Cranial B lines, which is going to be cranial B line, interstitial edema, cardiomyopathy, dilated upper lungs, and for pleural effusion. Good. Then remember, you said for good. Now, if you want to see if it's ruptured, so here, if you want to see a rupture, right? So when you have your aortic aneurysm, right? Now your aortic aneurysm, you're going to do for aortic aneurysm, we're going to do, if you ever smoked between 55 and 79 years old, ever smoked in your life, we're going to do one time abdominal ultrasound, right? Then that's going to be the screening minute. So, okay, aneurysm. Good. Now, if you want to see, you're going to CT with contrast, right? Then how to treat Gilbert diagram, right? So if you suspect someone who has aortic aneurysm, abdominal aortic aneurysm, right? You have the signs, which is going to be, you're going to have like a hypotensive sign, or what are you going to have? You're going to have abdominal cramping pain, right? And here, suspected of your abdominal aneurysm. Here. So, signs and symptoms you're looking at, is that, so ascending, so you have, okay, we're going to have exam, so you have abdominal pain, abdominal mass, or abdominal approach, right? Good, you're good. And then we see abdominal, so you have signs. So, and then, so looking at this SDF, so you're going to see abdominal pain, or back pain, or abdominal bruise, and all that. So if you see, so you have to check the stability, right? So, assessing, if you're unstable, where's the stable, right? If you're stable, what do you do here? If you're stable, what do you do? And then unstable, you have a history, you're still unstable. History of abdominal aneurysm, yes, you're going to do right. Should repair. Abdominal aneurysm, if it's going to be abdominal, you're going to, it's thoracic, it's over 6 centimeters treated, 5.5 centimeters, good. So 5.5 if it's going to be abdominal, thoracic. But if it's like rapidly enlarging, which is going to be grows 5 millimeters in 6 months, or 10 millimeters to good. That's what you're going to have to do. Okay, good, emergent. Good. Now, then, so history, so if it's, so then you do ultrasound. If it's absent, try to cause it, and then treat it good. And then if it's stable, you do CT with contrast. And if it's unruptured, so we're going to need it or expect it or just observation. And then ruptured, then we do repair. Good. Now, good. Now, we have good. Okay. Now, so after percutaneous coronary intervention, right, for long-term injury study, you have dual antibiotic therapy. It can be your aspirin plus Pursuit 2 gram Copitol, and that. And then it's going to just be basic bare metal for 30 days, right? And then it's going to be diluting for 12 months. Good. Now, first complication you have is arrhythmias, right? Your left atrial, which can be ventricular tachycardia, ventricular fibrillations, right? Secondly, you're going to have is going to be your pericarditis, your pericarditis, right? Your right? Which here you treat with, you avoid NSAID because you still have your life arrhythmias, but you're going to have your pericarditis. You're going to have your post-hepatic, post-infarction pericarditis, which when it says, that's what it is. Yeah, peri-infarction, still arrhythmias, peri-infarction pericarditis. Good. Then again with this one, when you look at nitroglycerin. Good. Now, nitroprusside, right? Average effects sign of poisoning. You treat it with your, which look for headache, dizziness, right? Treat it with your hydroxycobalamin and your sodium thiosulfate, right? Phenoxypan, remember you can increase sodium water infusion. Good. Gynecology, let's do obstetrics. Don't forget about those. Okay. Hear that shit? Hear it all night. Might just even be okay. Alright, 2200. Each piece, right? Times 2. No. 12. 219. next. Now, let's talk about the changes you're going to see in a pregnant lady, right? So when it comes to gastro and MSK, right? So gastro, the things you're going to see over here is that you're going to have increased esophageal sphincter relaxation, and you're going to have gastroesophageal reflexes, right? You have decreased decreased gastric motility, right? That's going to cause you to have motility, so constipation. You're going to have reduced venous return, which that's going to cause you to have hemorrhoids. And you're going to have reduced gallbladder motility, which is going to cause you to have gallstones, right? But the reason that causes GERD, you're going to have your esophageal sphincter reduced tone, esophageal sphincter tone, but increased, but you're going to have increased GERD. And then for MSK here, you're going to have lower back pain, usually in the fourth trimester, or third trimester, right? Because you're going to have subluxation of muscles. Good. Make sure you guys see empty, right? Push out the empty. Good. Shoulders. Good. Okay. Now preterm labor. So when you have preterm labor, it's where you're going to have normal uterine contractions. Normal uterine contractions are going to be 3 contractions every 30 minutes, lasting at least 30 seconds, right? 30 seconds, right? But you're going to have effacement and dilation of the cervix, right? Before week 37. And then in order to diagnose a preterm, you have to preterm, right? You're going to have to do requires whatever you just said over here. And then it requires assessing any kind of indication of cholytics. You want to reduce uterine contractions. So that's going to be if you have non-reassuring fetal status, intrauterine infections, right? Cord entanglements, again, requires assessing. Ultrasound to assess the fetal positioning, assess the AFI, right? And also chlamydia, you do assessing. And then you have to do assessing sterile speculum to remove lateral membranes. And then you do assessing sterile cultures, right? Culture, STI, ST, chlamydia, all those. Now, risk factors for preterm labor, and then preterm labor is that you're going to have, AP for HUT, right? So like, I think you're going to have AP for, I think it's PIT, P for your low, so low socioeconomic status, right? It's going to be, what else, between parentheses, A or in parentheses, what else are you going to have, stuff like that. And it's going to be short cervix by week 24, and then that's this. Yeah. So up it before your low socioeconomic status, right? You're going to have your rupture of membranes, that's another one. Your uterine surgeries like septate or precordial uterus. You're going to have two parentheses if you have any sort of infection. So preterm delivery. So preterm delivery transfers. It's the previous preterm delivery, right? Multiple twin pregnancies, some sort of infections, right? So previous preterm delivery, right? Multiple twin pregnancies, infections, polyhydramnios or oligohydramnios, right? Polyhydramnios, placental abruption, poor maternal nutrition, and placental abruption, polyhydramnios, placental abruption, poor maternal nutrition. Those are not status, right? Status. Good. We'll do that again. Right, so it's going to be a PIP before your low, right? So we're going to have this one here. Good. So we're going to have your PIP before your low, right? So you're going to have previous preterm delivery, infections, twin pregnancies, placental abruption, polyhydramnios, poor nutrition by maternal nutrition, your umbilical areolas by coordinate or spare surgery, and then your rupture membranes, and then your low socioeconomic status. Good. Okay, then what do we have to do? So we have your perinatal diagnosis, right? So remember, you're going to have the, how do you do it? So from 0 to 28 weeks, it's going to be once every 4 weeks, right? From 29 weeks to 35 weeks, it's going to be once every 2 weeks, and then once a week is going to be from 38 weeks to delivery, 42 weeks, right? No, 36 weeks to delivery. Right? Good. Very good. And then you're going to have the initial visit, which you're going to do the initial visit, right? Then you're going to have to do initial visit, then we have at 18 to 20 weeks, right, we have the ultrasound, right, for the fetal 18 to 20 weeks. We have the ultrasound for the fetal embryonic reading, and then 10 to 20 we do 22 we do aneuploidy screening, and then we have your 24 to 28. We're gonna do your 1 hour glucose tolerance test, and then some information, and then from weeks 28 to 30, we're gonna have your radiation administration, right, and then from 35 to 38. This is what we're gonna do your or 37, right? This is what we're gonna be doing your Group B rectal swab. Group B is culture, right? We see, and then from 34 to birth, or so 40 weeks, right? This can be high risk pregnancies. You do rapid plasma reagent for chlamydia, STI, HIV, pregnancy, stuff like that. Good. Okay, now so we have these fetal heart rate monitoring, right? So what are the components? There's 2 ways. You can do non-invasive, which you're gonna have the external Doppler right over here, okay? Or you can do the invasive, when you're gonna put electrodes on the fetal scalp. This is gonna be only if you have you have ruptured membranes, right? So ruptured membranes, or no, pregnancy with fetal growth restrictions, right? Fetal growth restrictions. Good. Now with the components of your heart rate, you're gonna have your the rate, right? Variability, acceleration, decelerations. Now, with tachycardia, which is going to be over 160, then you have below 100, is going to be bradycardia, right? Now, tachycardia, what can be the causes? So bradycardia can be congenital heart defects, or it can be your what was it going to be? It can be severe ischemia. So ischemia secondary to what? Secondary to rapid descent. Cord infection, rapid descent, or cord prolapse, right, from cord compression. And then here's going to be severe ischemia, right, intrauterine infection, maternal feeder, tube feeder, defects. Good. Yeah. So. Bradycardia, so that's what tachycardia is. Including hypoxia, intrauterine infection, and then so it's going to be hypoxia, severe uterine hyperstimulation, cord prolapse, so it's going to be severe hypoxia. Don't forget that, severe hypoxia. So we're going to have severe hypoxia, right? Secondary to rapid fetal descent, uterine hyperstimulation, or cord prolapse, and then it's going to be severe hypoxia, maternal fever, intra-amniotic infection, or pneumonia. Good. Okay. Now we have, so what is it? So when you have your early recurrence, it's going to be before 13 weeks. It's going to be from 13 weeks to 20 weeks, right? 13 weeks to 20 weeks. That's what it is. Now it's going to be congenital heart defects, right? It's going to be so early recurrence financial portion, right? First trimester, which is going to be before 10 weeks. Before 10 weeks, I guess, right? Before 10 weeks. That's first time. Okay, before 10 weeks, and that's going to just be what? So for 10 weeks, that's just going to be so for 10 weeks, right? Or maybe 10 weeks, right? That's just going to be due to congenital or fetal chromosomal defects, right? Congenital defects, right? Okay. And then it's going to be due to if you have your late financial portions, it's going to be due to what? Hypercoagulative state, general hypercoagulative state, uterine malformations, or like you're going to have your hospital positive. You're going to have your what else? You have hospital positive. That's going to be positive. Hypercoagulative state, or you have uterine abnormalities. Good. So that's what I said. So you're going to be before 12 weeks, right? Before 12 weeks. Make sure we realize that I'm safe. Then target, make sure we're going to this. Good. And then right before 20 weeks. Good. So we have before 12 weeks, right? Until 20 weeks. Good. Yeah. Very good. Now we have aneuploidy screening. So we have your blank screen for aneuploidy testing, right? So you can have your we have your coronary sampling. That's gone. We also have your coronary sampling, cell-free DNA sampling. Also we have your amniocentesis for this one, right? Now go over results. So we have your complete your quadruple screening. Which quadruple screening includes your beta ACG, includes your alpha protein, your estradiol, includes your beta ACG, and your inhibin A, right? Now these are going to decrease, right, for for your trisomy 18, but for trisomy 21 up, all they're gonna be up. Good. The screening's done between weeks 1 and 22 every 4 weeks, right? So you have 4 screenings done every 4 weeks. No, sure. So you have a fetal protein. So your trisomy 21 is going to be decrease, right? For trisomy 18, very good. That's going to be done. Good. Now, risk factors plus your placental abruption, placental previa, and your vasoprevia, right? Placental abruption is going to be just detachment of the premature detachment from the placental side of implantation. It's going to be the risk factors include your rep hat. It's going to include previous placental abruption. It's going to be excessive stimulation of the excessive stimulation, and also rapid fetal descent, hypertension, alcohol, cocaine, tobacco, cocaine use, right? And it's going to be adrenal trauma. And then for the previa, it's going to be puma, previous placenta previa, going to be uterine abnormalities, multiple gestation twin pregnancies, advanced age, and prior C-section, right? And then here's going to be your MIPS. Your in vitro fertilization, right? Your pregnancies, your single umbilical cord artery, and your previous placental. Good. Very good. And then we talk about symptoms for this one. This is going to be, you're going to have painful bleeding, uterine bleeding, right? That does not go away. Painful bleeding, right? Does not go away within 2 hours. You're going to have your hypotonic uterus, right? And also you're going to have fetal distress, bright red, bleeding, painless, no fetal distress that goes away after 1 or 2 hours. And here you're going to have bleeding at the side of bright red bleeding after painless bleeding at the ruptured membranes, right? So your capacity. Painless breathing, and then painless bleeding out of the membrane, fetal bradycardia. Good. Okay, now go over to details, right? So, before we go on here, go over details for the screen. So the initial test we're doing really good, and then we have the initial visit. So the initial visit here, we're going to go over. First thing we're going to do is your hemoglobin, right? We're going to do your fetal blood typing, right? Cross matching, and your artisan dilation, and then the CBC screening for importance, right? Determine. Okay, good. And then after that, you have to do the infectious disease test, right? So you're going to have your hepatitis B surface antigen test, right? You're going to have your hepatitis C, looking for hepatitis C antibodies, right? Looking for your rubella titers, right? Looking for your rapid plasma reagents, right? To rule out any sort of rapid plasma reagents to rule out your HIV or tuberculosis, right? PBD for HIV and tuberculosis, rapid plasma reagents for syphilis, right? What else? For gonorrhea, chlamydia, right? And then for other tests, if you're for like familial, right? You're gonna look for what? You're looking for if you have to do, you're gonna do HbA1c testing, right? If needed, or sickle cell disease testing, right? Familial Tay-Sachs disease, cystic fibrosis disease, right? Or like spinal muscular atrophy, and then HIV tuberculosis, and then 2 pap smear for, and you consider MR vaccine or a varicella vaccine needed. Hepatitis C vaccine and varicella vaccine based on history. Good. Now at 10 to 22, right, we endpoint screening. Cell-free DNA is going to be the main. It's going to be the most sensitive and most specific tool. It's a specific tool for trisomy 13, 18, 21. It can be least invasive as well. And then you can have your full integrated test, which you use for serum pregnancy associated platinum protein A, harvested from week 10. Correct between weeks 11 to 14. And then you have the crown to rump length, usually at week 9, week 10 to 14, plus the quadruple screening, which is going to be your beta-2D, your estradiol, your fetal protein, and your inhibin, right? Inhibin. And then you can do combined tests with beta-2D, PEP, and then neutrogeny 11 to 14 weeks, which produces the combined test is beta-2D. Your PEP A measurement, which is really good. 19, 20 weeks or so, ultrasound, and then 24, 28 weeks. That's where you do your basic one, IDs, right? Okay, good. And then 35, good. So we have your, don't forget, You can do so you can do the hepatitis C vaccine and various other vaccines based on immunity. Good. And then remember the combined test can be your beta HCG test, right? CD and neutral translucency to the 14. Good. You're okay. Good. Okay. Now how's the test about you? So we have your contraction stress test, right? This test is going to be performed in what position? In your lateral recumbent position, right? And recumbent position. Recumbent position, right? The fetal heart rate is going to be measured by a Doppler via normal, spontaneous, and oxytocin-induced unique contractions. Good. And then what are the contraindications to doing the contraction stress test? You need to be, if you're going to have a preterm delivery, placenta previa, uterine abnormalities for like placenta previa, right? Preterm delivery and placenta abortion, something like that. So preterm membrane rupture, preterm membrane, right? Placenta previa, history of uterine surgeries, or high risk for preterm delivery, right? So preterm rupture membranes, placenta previa. High risk for preterm labor and uterine surgeries. Good. That's a positive, negative, or equivocal, right? Now, positive is bad. This is going to be we have a complete test. We have late fetal heart rate deaccelerations when 50% or more, whether you do contractions have gone within 10-minute window, and it's going to be indications for delivery and fetal compromise, right? Then negative is going to be no fetal heart rate deaccelerations, and equivocal is that you're going to have some sort of variable deacceleration. Good. So preterm delivery, right? Placenta previa or I'm not sure membranes. That's good. Now we have the tachycardia, right? So we have tachycardia. Good. That's going to be severe hypoxia. Maternal. What else? Maternal fever. If you have your maternal fever, cord prolapse or internal infection, fetal anemia. Cord prolapse, severe hypoxia secondary to cord prolapse, right field descent, or your hyperstimulation or hyperstimulation. The variability is that you're going to have abnormalities, fetal heart rate from baseline with abnormal frequency and amplitude, right? Variability from the baseline. Good. So we have your fetal heart rate, right? Usually variability to be 6 to 25 beats per minute, right? It can be minimal. Which is absent. Minimal is less than 6. Normal is 625, or it can be marked, which is 125. Marked can be a predecessor to decreasing fetal heart rate, right? To minimal, right? And you have sinusoidal and sinusoidal pair being used, right? Certain pair being used, right? First off, you can be absent, which is this can be due to severe fetal anemia, right? Fetal anemia. So I think first one is going to be due to fetal anemia. No, fetal acidemia, right? So again, this can be related to fetal cerebral activity. This can be acidemia. I got it. Minimal is fetal hypoxia. Fetal hypoxia, or the effects of magnesium, opioids, or sleep cycle, right? So fetal hypoxia, right? Hypoxia. So acid. Fetal hypoxia, the effects of magnesium or sleep cycle. Effects of opioids. Good as normal. And then variable fetal hypoxia again. Hypoxia. Fetal anemia. Good. And then so acids, fetal hypoxia, right? Secondary to or effects of sleep cycle, opioids, and magnesium. And then you have normal, and then marked due to fetal anemia. Fetal. So we have marked you have fetal hypoxia. And sinusoidal is going to be anemia. Good. Okay. Now T2. T2, TV, Volkswagen, right? So we have your tetracyclines and your minoxidil, right? Minoxidil, tetracyclines, right? Tetracycline, right? You can have your hypoplasia, enamel hypoplasia, or your permanent brown yellow discoloration of the teeth, right? Acetylcholine is not contraindicated to pregnancy, right? And then you have your thalidomides, right? And then you have your trimethadone and your paramethadone. And you're going to have your vitamin A. Then you have your vitamin A derivatives, right? You have your warfarin, and then you have your valproic acid, right? So thalidomide, right? Thalidomide, if you look at this one, you're going to have your You're gonna have your BAM, right? You're gonna have your BAM, right? So you're gonna have your bilateral limb defects, right? Inertia, microinertia, problem with your ears. Your trimethadone, paramethadone here. You're gonna have your I think you're gonna have your congenital. You're gonna have your cleft, your congenital heart defects, right? Cleft palate and other line. Good. The catch, you're gonna have your congenital heart vascularity and responsibilities, right? And then your valproic acid, and vitamin A, right? So vitamin A, estrogenic, right? Valproic acid, I think you're gonna have increased neural 2 defects. Sulfuric acid, neural 2 spina bifida. Then here you're gonna have your tick, right? You're gonna have your thymic aplasia. You're gonna have your cleft palate, cardiovascular defects, right? Cleft palate, and touch disabilities as well. And then more fair and warm babies. Here you're gonna have your Dunn's fall, right? You're gonna have your finger hyperplasia. You're gonna have your stippling of the epiphysis, right? You're gonna have your nasal hyperplasia. I think fingernail hyperplasia as well. No fetal growth restrictions. Hyperplasia as well. You're gonna have your fetal growth restrictions. So and developmental delays. Good. Burn, right? Good. Now, postpartum treatment for what does postpartum treatment? So you can have 12 hours. So 24-hour prophylaxis of my needs to be continuous, right? For look-after necessity. The complications of preeclampsia is going to be chat, right? Chat. So eclampsia is going to be what? You're going to have your cerebral hemorrhage, aspiration pneumonia, thromboembolism, thromboembolic events, and your good. So the same thing. So here's postpartum 24-hour, the same thing, and then your hypoxia is already. So like we actually have about 40 hours. So it's 24 hours. Okay. That'd be good. Now what is over here? You're good. Now what is considered a non-viable? Okay, good. The best initial test for your spontaneous abortion. Spontaneous abortion, right? What would be the best spontaneous abortion? I think the second test for that you're gonna check the beta-HCG levels. The spontaneous abortion here is I think you're gonna check the you're gonna do a vaginal ultrasound, right? Transvaginal ultrasound, pelvic ultrasound, right? And then next is gonna be your check your beta-HCG levels, I guess, right? Then to diagnose it, it's going to be just by looking at it, right? And then after you do the ultrasound, you're going to do and then treatment for spontaneous abortion. If it's early, you're going to give your early sensation, right? Good. Now, so ultrasound, right? So now, okay, good. Now ultrasound, identify the following. The transvaginal ultrasound, right? So gestational lasts 5 to 6 weeks, period. Remember your growth length, 6 to 7 weeks, right? And the fetal cardiactivity, right? Fetal pole, cardiactivity 6 to 7. So the fetal pole is going to be 6 weeks, and then 7 weeks. Fetal cardiactivity 6 to 7 weeks. Good. Now polyhydramnios, meals, right? It's going to be too much in food. So the fine is going to be an AFI of 23 or greater, or the deepest pocket. 8 centimeters, right? 8 centimeters or greater, right? The in-air pocket, 8 centimeters. The call is going to be fit, tolerable, right? So it's going to be, okay, well, this one's going to be gestational diabetes. This is going to be multiple pregnancies, so twin pregnancies can cause it. No, twin pregnancies, this one. This can be, okay, this can also be your, it can be your, what else can it be? It can be pulmonary edema, I guess, or like pulmonary embolisms, I guess. Something like that, congenital pulmonary ischemia, something like that, right? It can also be due to twin pregnancies, like I said. It can be due to your fetal. It can be due to your tracheoesophageal fistula. It can be due to your, let's go over this, right? Presentation is asymptomatic. How to diagnose here is that, I think how to diagnose here is that you're going to ultrasound to measure the quadrants, right? You get the sum of all 4 quadrants. The treatment here is that you're going to do amniocentesis to drain the amniocentesis conditions with serial drainage. The complications from these can be you can have your fetal premature rupture, right? You can have your cord prolapse, entanglement, all that stuff. So fetal malpresentation, cord prolapse, preterm labor. Good. And the therapy is indeed good to remove it. And good. Now, okay, fit palm. Over here. So it's going to be high fit palm. So okay. So you can have fetal gestational. So duodenal region trichosophageal encephaly, right? Duodenal region trichosophageal fistula or encephaly. And then iso immunization. Like it's like your oral iso immunization. Your multiple your fit two pregnancies, right? So the P is going to be your pulmonary embolism, cystic lung malformations, and then it's going to be your what's this one? Maternal diabetes or multiple gestations. This is going to be your fetal gastrointestinal anomalies, right? Such as your duodenal atresia, your trichosophageal fistula, encephaly. It's going to be iso immunization, right? Fit is going to be twin pregnancies, right? The twin transfusion syndrome, right? Twin transfusion syndrome. Fit palm. Multiple pregnancies, right? Maternal diabetes and your cystic lung malformation. Good. Okay. Now we have your types of spontaneous abortion. So we have your complete, incomplete, and then threatened. Got it? Now, incomplete is going to be open cervical it's going to be closed cervical right? Good. Now, in closed cervical you're going to have cessation of abnormal bleeding and abdominal cramping, right? And you're going to have expulsion of product from conception. So ultrasound, no product from conception, right? And you're going to have closed cervical Good. Good. And then you're threatened here. Threatened here is that you're going to have your painless bleeding, or may or may not have abdominal cramping, you're bleeding or painless, but no product conception expulsion. So closed cervical and product conception seen on ultrasound, right? And so remember, you're going to have intact membranes. That's why fetal cardiac motion on ultrasound. So you have to do scheduled follow-up to assess your fetal viability, right? You're going to have your incomplete. So that's why you're going to have your open cervical rupture membranes, and you're going to have in probably 17 ultrasound, and so bleeding and cramping. And if it's going to be if it's less than 12 weeks, maternal uterine aspiration, right, or so weeks, or you can do dilation, correct? Good. So threatened here is that you're going to have we're going to have threatened is that you're going to have asymptomatic bleeding, right? Painless bleeding, and you have cramping, and no product conception. So that's where you can take product conception ultrasound. Fetal heart rate's going to be detected. You're going to have closed cervical and you're going to have intact membrane. That's where you just schedule the follow-up for all cystic fetus, right? And then partial expulsion, bleeding, or cramping, right? So that's where you're going to have rupture membranes. You're going to have open cervical product conception, tissue dilation. And that's why you're going to have to do maternal uterine aspiration in 12 weeks. Is that dilation correct? Good. Complications of analgesia, right? So we have complications, right? Or contraindication. So you have spinal headache, which if the spinal headache just occurs, if you dural puncture, you can have your epidural post dural. You can have hypertension, right? Which is going to be due to back of the sympathetics, right? Hypertension, back sympathetics. Only if you have shock, hypertension, right? Only if shock you treat it. Patient that actually have to treat it. Hypertension, right? So spinal subtralia, hypertension, sympathetic block, common hypertension, we treat it as a shock. You're going to have your anuria, right? No peeing, so you treat catheter, treat with catheter, right? So epidural, seizure, postpartum, urinary retention, right? Contraindications you're going to see here, if you have untreated bacteremia, if you have increasing intracranial pressure, you don't want to do it, or if you have some sort of skin infection or untreated bacteremia and skin infection with right? If you've taken daily low dose aspirin in the past, or low molecular heparin within the past 24 hours, 24 hours, right? That's another contraindication. If you have okay, good, and then respiratory maternal hypotension or maternal coagulopathy, good. So respiratory hypotension, if you have maternal coagulopathy, good. Hypotension, respiratory hypotension, coagulopathy, and 20 hours. That's 20 hours, good. Good. Now, so we have asymptomatic bacteria, right? So most common cause is going to be E. coli, and then diagnosis. Okay, you're always going to do a urine culture and urinalysis and culture for diagnosis of any of these, right? The history of these in terms of this one, right? So history, how they're gonna present. So your asymptomatic bacteria, your UTIs, and your pyelonephritis, right? So appendicitis, you're going to have you might have some sort of fever, coastal illness, right? And asymptomatic bacteria around week 10 to 14. You're going to have positive cultures, right? Titers, right? And you're going to have so 12 to 16, you're in cultures, 50 colonies, right? You're going to have you have dysuria, urinary frequency, urinary urgency, and fever, coastal representatives. Good. Good. Okay. Now variability. Okay. Now when you have this, you're going to have acidemia, right? Acidemia, hypoxia, and then anemia. Good. So this is absent is going to do the fetal acidemia, right? Minimal, less than 6 features per minute. If you do the fetal hypoxia or a sleep cycle using opioids, then you're going to have your mark is going to be due to fetal hypoxia. Then also there's going to be sinusoid fetal anemia. Good. Then essentially good. Normal. So let's do this. We have your good. Now, oncology is right. Going to be an AFI of 23 or greater, or your particular 8 centimeters or greater, right? Deepest pocket causes can be fit palm. You can have your feet open in malformations like duodenal streakoesophageal fistula, or encephaly. It can be your ISO immunization, right? Arch, right? ISO, right? It can be your multiple gestation, multiple pregnancies, right? It can be your pulmonary problems like your cystic lung malformations. It can be your maternal diabetes. Also can be due to your fit physical syndrome. Good. Now history. So when you're using 12 to 16 weeks, you're gonna have your colonies, your colonies, right? Yeah, and then dysuria, increasing your frequency, urgency, and then fever, plus the dysuria for appendicitis. Good. now, so when I do study like this, right, at nighttime, I try to think of TikTok ideas for the next day. So I'm thinking about this one. It says this one idea. So like my sister always asks me to buy her stuff. So like POV, your brother's a doctor, so he spoils you. Now how can I make that funny? So maybe I can say like, I get mad. Mad at the credit card bill. I have a spare something we do something. But yeah, stuff like that. I'll complain about buying things for Maria that I didn't actually buy for her. I got one more set of Anki cards to do, right? The big one. And then after that, I'm gonna do ovarian cancers, finish that up, and then tomorrow I'm gonna finish all the little things, and I'll be done with this. First, I want to watch IQ dating test. Okay, choose one of the variants to replace the missing shape. Sure. So this one, down, down. Okay, good. Down, down, down. No, sure. This one, okay, good. Good. Okay, down. This one, okay. This one. Okay, we have 1, 2, 3. This one has to be this one. Okay. So, this is where? Try so. Large triangle. Good. Shape. Missing shape. That's pretty easy. Good. This way, right? So we have this way. Right, we have this way. So we have this way. This is cut this way. It's cut. So we have good. So we have this one, right? So we have this one. So this one's cut like this way. What's the pattern? Good. What's this one over here? Also this one. 1, 2, 1, 2, 4, 8, 16, 32, 64, 9. Wait, is that this one? We have your doing an IQ test right now. Same side, same side. Right, same side. Middle, middle, middle. It has to be the same side. Just be over here. It's over here, right? It's over here. So it has to be on this side, right? It's on this side. So since this is in the middle, this side, right? But where's this gonna be? This one, which is going to be one, two, three. That's easy enough. I really hope I don't have to pay for this. Wow, they didn't even give me a fucking grade. Are you kidding me? What a waste of time. I took an IQ test and they like told me I should have known. Need a test in 10 minutes, right? Go to my results. Fuck you. Not paying for shit. Sweating after that shit. Let's finish up. All right. Let's do this shit. Obstetric or gynecology. Okay. Now, diagnose. So most breast cancers are going to be diagnosed via mammograms, right? Screening, the way it works, if you're less than 34, if you're less than 30 years old, you're going to do ultrasound, right? But if you're going to be greater than 30 years old, you're going to be or 30 years or greater, postmenopausal, you're going to do your mammogram, right? Now, let's go to the page. Oh, this is going to be for breast cancer. Now, when you do the mammogram, so what's really good about this is that you can see microcalcifications, you can see densities, right? You can see densities, microcalcifications. You can see nodes that won't be palpable for 2 years, right? Spicular lesions, right? Then if you're premenopausal, you can do because the dense breast tissue, you can do an ultrasound, which is showing increased densities. Good. Now, special cases, if you're going to have like a BRCA1 carrier, BRCA1, BRCA2 carrier, if a first degree relative BRCA carrier, right, where you're going to have a 25% chance increase in life risk of getting breast cancer, you're going to do a yearly MRI screening. Good. Okay. Now, what is this one? Now, go to page 502. So, staging for. So, when you have your invasive, so how do you stage invasive cervical cancer, right? So stages 0 through 4. Stage 0, that's going to be your carcinoma, cervical, or your carcinoma in situ, I think it is, right? So it's okay. So it's invasive, but it's still at bay, and 92%, so 92% per 93% 5-year survival rate, right? Stage 1. This is where it's going to be. You have stage 1A and 1B. It's going to be, it's contained into the uterus and the cervix, right? 1A is going to be the I think the endo, the external loss, and then into the cervix, right? And then the cervix, right? 1B is in the cervix. Now you have you have 2A and 2B. Remember, 1A is going to be 93%, it's going to be 80% survival rate. And this is going to be where it's going to go outside of the uterus, outside of the cervix, right? But not to the lower third of the vagina, and also not to the pelvic walls, right? And then 3A, 3B, that's where it's going to go to the lower 1/3 and also to the pelvic walls. And then 4, that's going to be where it's invasive, where it's going to be like metastasis, spread to the rectum, to the bladder, right? Now, how do you treat invasive cancer? Now, for your microinvasive cervical carcinoma here, which is type 1A1, you can do 2 things. You can do your what else? So you can either do your simple hysterectomy, I believe, or you can do your pap smear plus observation. Okay. What's it gonna be? So you can treat cone biopsy, but so cone biopsy and close follow up plus hysterectomy, right? Before your class 1B, 1B1, 1A2, 1B2, and 1B2. No, 1B1, 1A1, 1A1, 1B1, 1B2, and class 2A. You can do your radical hysterectomy plus chemotherapy, I believe, right? And then for class 2B and 3 and 4, you're going to do chemotherapy. No, you're going to have radiation plus cisplatin-based chemotherapy. Good. Okay. Now, how to diagnose? Okay, answer. So congenital adrenal. So we have your congenital adrenal hyperplasia, right? How do you diagnose this, right? So we have 21 hydroxylase, and then we have your 11 beta hydroxylase, right? So in both cases, for 21 hydroxylase deficiency, you're going to have an increase in 17 hydroxyprogesterone because you cannot convert your 17 hydroxyprogesterone to 11 into your 11 deoxycortisol. So you're going to give addition to that, and you're going to do the newborn screen. You can do is the ACTH cocinotropin stimulation test, but it's not really needed if you have high 17 hydroxyprogesterone, right? Then for your 11 beta hydroxylase deficiency, you're going to have increase in your 11 deoxycorticosteroid. Good. Now then you're going to check for your cortisol levels, going to be low for both, and then you're going to check your androgens. Your androstenedione levels are going to be elevated for both, right? But so this is associated with your ovarian cancer, right? And then you're going to have your high dihydroepiandrosterone for both as well. Good. And then we have to treat. The treatment. Okay. Now treatment for your, and we have to go to the tables. So the first thing for your 21 hydroxylase deficiency as well as your 11 hydroxylase and 11 beta hydroxylase, how you treat it. So first off, you're going to have glucocorticoids, right? You're going to use your, I think the first one you're going to use is you're going to use your dethomexazone, your dethomexazone or something like that, right? Please, your right? Your dexamethasone, right? Dexamethasone, what this is going to do, it's going to inhibit the new onset of bulbar hairs. It's not going to inhibit hair retention, but it's going to stop like new terminal hair growth. Medical treatment for adrenal and ovarian disorders. Then you can do also additional therapy. You can do mineralocorticoids. You can use finasteride. You can use your fludrocortisone. Now, fludrocortisone is going to treat for 21 hydroxylase deficiency if you have salt wasting, hypotension, right, and salt wasting with hypotension, right? And then you can do laser ablations run on therapies, right? Don't forget dexamethasone, fludrocortisone. Good. Now, when you have any sort of congenital adrenal hyperplasia, you're going to have bilateral adrenal enlargement and hyperpigmentation because you're going to have decrease in cortisol, right? Increase in ACTH. So that's what's going to cause you to have a decrease. Very good. Now, in any case here, whether you have your 17 alpha hydroxylase, your 21 hydroxylase deficiency, or your 11 beta hydroxylase, you're all going to have decreased cortisol, right? But 17 alpha hydroxylase, what's so good about this one? In this case, you are going to have so this one you are going to have a decrease of your androgens, right? Decreased androgens. So you're going to have for XY, you're going to have ambiguous genitalia, right? XXX for females, you're going to have lack of sex reduction, other testes, right? And you're going to have when it comes to your mineralocorticoids, right? Your aldosterone, it's going to be you're going to have increased aldosterone, right? So you're going to have increased in decreased sodium. No, you have decreased potassium, increased sodium. Sex hormones are going to decrease in that one. Good blood pressure going to decrease as well. Now for your 21 dosages, right? Mineralocorticoids, which is your aldosterone, that's going to decrease, right? Right? Cortisol is going to decrease as well. Sex hormones are going to increase. Blood pressure is going to decrease. Hypertension, you're going to have increased potassium. You're going to have increased renin activity, right? Because you're going to have reduction in 70. You're going to have you're going to have XY. You're going to have XX. You're going to have large penis, right? And bigger realization, female realization, right? Common. 11 beta, we're going to have decrease in your aldosterone, but increase in 11 deoxycorticosteroids, which is going to be the same thing. So you're still going to have you're going to have decrease in potassium, increase in sodium, decrease in blood pressure as well. So it's going to work the same. Sexual organ good. And then you're going to have decrease in activity, and you're going to have female XX realization. Good. Now remember, you have dexamethasone, fluticasone as well. Okay, good. Now, so how to diagnose? So we have your primary. Remember your primary amenorrhea. Then primary amenorrhea, secondary amenorrhea. The first thing you always want to do is this amenorrhea is like you're gonna have lack of menses, right? Good. So amenorrhea, right? So okay. So you want to do pregnancy test to rule out pregnancy for their secondary or primary, right? Then after you do that, then what you want to do here is that so amenorrhea can be caused by a couple causes, right? So then you want to do a like a pelvic examination, an ultrasound, right? To look at the anatomy, to look at and rule out and perforate hymen, right? And then if your uterus is present, what do you want to do here? If your uterus is present or your uterus is absent, what are you doing? Looking at your FSH levels and you're looking at your testosterone levels, right? And also you're looking at your karyotyping, right? If you're gonna have XY, right, male and normal male testosterone, you're gonna have your insensitivity for XX, right? And or female, you're gonna have your miliary dysgenesis, right? Now if your uterus is but if your uterus is present here, you're looking at your FSH and LH levels, right? Now if your FSH levels are increased, right? What do you have? You have your primary ovarian insufficiency, right? And then if you have normal or decreased LH levels, right? So primary ovarian insufficiency. Now to karyotyping, to rule out Turner syndrome, right? Now so this is going to be your constitutional, right? To check out your prolactin and your thyroid levels, especially in presence of bacteria. And then if you have signs of what sign you have hyperandrogenism, right? Looking at what? Looking at your signs of hypertension, which are looking congenital hypertension, congenital hyperplasia, or your 17-hydroxyprogesterone, good. And the hyperandrogenism signs, 17-hydroxyprogesterone, or your dihydro. Are you looking for hyper? Good. Yeah. So uterus present, so good. Uterus present, primary insufficiency, and then very good. And normal. Let's see if you have normal decreased FSH, you're looking for your hypogonadism, constitutional, good. Adrenal secreting neoplasia or hyperplasia. Okay, good. Good. Now, how do you treat this? If you have a constitutional thing, just leave it. If you have signs of hypoandrogenism, so hypogonadism here. So begin with estrogen hormone replacement therapy, estrogen, and then after 12 to 18 months, being cyclic progesterone estrogen therapy, right? If the uterus is present, and then for any sort of anatomical surgery, surgical intervention. Good. See that? So again, if it sounds hyperandrogenism, so you're interested in neoplasia, can you have dihydroxytestosterone? Good. And then treatment for secondary amenorrhea. So secondary amenorrhea treatment. So it's going to be like so let me read the pregnancy here. So if you have a hypothalamic pituitary gonadal axis, right? So hypothalamic ovarian axis. Reversal, they only cause if fertility is wanted, you can give fertility drugs, but if you're done with that, you can have organ conceptus, right? If not, organ conceptus. If you have some sort of tumor, like a tumor such as a pituitary, you can do surgical excision. But if you have pituitary adenoma, you're going to do your cabergoline or cryptine, right? Tumor, right? And then if you have some sort of premature ovarian, or if you have premature ovarian insufficiency, right? So before age 40, what are you going to do here? So if you have your premature ovarian insufficiency, which is going to be a menopause before age 40, You can start it with, so here in the uterus present, uterus present, you can do it with what? You can treat it with your non-hormonal contraceptives plus estrogen or progesterone. Good. Or contraceptives plus estrogen or there. Good. Good. Now, do key facts. Now, what else is so insane? So 21. So 84. So we're doing do figure 21. Okay, so if you have for infertility, right? So infertility, right? You can be male factors 20%, female factors, right? Male factors, what they can be, you can have your primary hypogonadism, where you can have increased FSH and LH, or secondary, where you have decreased FSH and LH, right? And then you have to stick with this fertility, right? The source sperm transport. And male, it can be 8, it can be amenorrhea or towards source. It can be due to endometriosis, or it can be due to tubal defect, right? Now, when it's having amenorrhea or ovarian defect, it can be your primary ovarian deficiency, polycystic ovarian syndrome. It can be your you can be hypothalamic pituitary problem, right? Or tubal, or uterine. Very good. Okay. Now, presentation of your uterine leiomyomas, or fibroids, right? Now, presentation is going to be your black man's BP, right? The added diagnosis here is that you're going to do CBC, check for anemia, because you're going to have, when you're going to have your bleeding, right, you're going to have heavy menstrual menorrhagia, right? That may lead to anemia. Your bleeding, right, means anemia, right? You're going to have your mass effect, which is going to be your pelvic or rectal pain. You're going to have your pelvic rectal pressure, right? You're going to have your constipation, urinary frequency, urinary retention, right? You're going to have pelvic disorders, right? You're going to have secondary amenorrhea, dyspareunia, and also you're going to have your fine uterus, right? You can have your fixed, immobile, non-tender, enlarged, cobblestone, lumpy, bumpy, uterus, right? Good. Then, memorizing the best visualizations. First off, you're going to do is pelvic examination, right? And then after that, you can do your ultrasound, right? Which can see your uterine, you can see myomas, right? Calcifications, you can see necrosis as well. Then you can memorize the best visualization. You can do it pre-surgery or around the leiomyosarcoma. And this can see if it's going to be your myomas are going to be intramucosal, subserosal, okay, got it. So, non-tender, living on B, good. Mycosis and ovarian masses, serosal, submucosal, good. Now, how do you treat this, right? If you're fibroids, right, uterine leiomyomas, if it's asymptomatic, you're going to do any pelvic exam with CBC, right? And you have virological or surgeries, right? Now, if fertilization is still you can do your myomectomy. You can do your hysteroscopic if fertilization is finished. If fertility is finished, you can have your hysterectomy, right? You can do immediate surgery if you have any sort of pedunculated torsion, or then you have uterine artery embolization if further situation is dangerous. Okay, good. Complications can be infertility, we know that. Then if pharmacological treatment can be NSAIDs to reduce pains. You can do your oral contraceptives, combined oral contraceptives, right? Medroxyprogesterone sulfate, and also you can do your danazol to reduce bleeding. Stop bleeding. And you can have your gonadotropin release hormone analogs, your leprolide, and your nafarelin to reduce the vascularity, reduce the growth, and reduce the spread of the myoma, and also reduce uterine size, and also for your painless hysterectomy. Good. Now, what reduces the risk of endometrial cancer? It's going to be your hormonal restoration. Now, treatment for your endometrial carcinoma. So, endometrial carcinoma is going to be within the endometrium. So I think it's going to be, for endometrial service, you can have your endometrioid or serous. Now, first one you can do is that you can do your, if it's going to be local excision, right? But you can do hysterectomy plus bilateral salpinectomy for ectomy, hysterectomy plus bilateral, right? So high dose progesterone for women who desire fertility. Then postmenopausal is going to be radiation. Adjuvant chemotherapy and radiation if it's advanced stages. Good. Okay. Now, phyllodes tumor. So phyllodes tumor, when you look at it, it's going to have like a leaf-like pattern. So a leaf-like appearance over here. Now, phyllodes tumors, when you see differentiated fibroadenoma, is going to be more metastatic, has more metastatic ability. And differentiating features is that you're going to have these protruding phyllodes tumors, papillary stroma with hypertrophy. atypia associated with epithelium and hyperplasia atypia, right? And final tumors have to be excised, but you don't have to remove the axillary node. The axillary nodes, dissection not necessary. Good. Okay. Now, non-neoplastic ovarian cyst. Now we have your fibrocystic change, right? Your fibroadenoma, and also your fat necrosis of the breast tissue. That's what it is. The characteristics of benign ovarian cyst. Now these are going to be ovarian cyst, right? Now you can have your your follicular ovarian cyst, right? Your physiological ovarian cyst, right? And you're going to have your TCP, your FTC, and then just you're going to have, okay, good. And these are going to be characteristics of ovarian cyst. It's going to be under 8 centimeters, less than 45 years old, under 45 years old, right? They're going to be simple cyst, right? And unilateral. It's characteristics, right? Cysts are so benign, unilateral, good. And then, so this is non-neoplastic ovarian cyst. And we're going to have your follicular ovarian cyst, right? Corpus ovarian cyst. Your FCT, luteoma, right? Luteoma, good. Now, follicular ovarian cyst, physiological cyst, right? Now, we look at so this follicular, this is going to be for your follicular ovarian cyst. This is going to be when the follicle fails to rupture and release the mature ovum, and continues to grow, so it does not release the ovum, right? And then your corpus luteum cyst, right, is that you have the failure of the corpus luteum envelope, and it's going to post-ovulation, it's going to keep growing, so large. The luteum cyst is going to be excessive HCG, excess stimulation, right? And your luteoma, it's going to be associated with pregnancies, hirsutism, and realization, right? And you're going to be all right, good. So luteoma is good. Now, toxic shock syndrome. Now, toxic shock. This is going to be from the toxic shock, the reformed toxin shock, toxin 1 from Staph aureus, right? That's why you have blood culture negative, because the preformed toxin, not the bacterium that causes it, right? Now, it's also going to be when you leave your tampon in for too long, or it's going to be for like burn wounds or surgical wounds after surgery. Good. History of presentation, you're going to have fever, so it's going to see dandy, right? And we're sad, you're going to have abrupt onset of fever over 102 degrees with Celsius, right? You're going to have fever with nausea and water diarrhea. That's one. You're going to have this abrupt onset of your you're going to have non-pruritic conjunctivitis, right? Non-pruritic conjunctivitis, that's what they call it. So non-pruritic conjunctivitis, right? You're going to have the desquamating pollen cell rash upon healing, desquamation, especially on cells during the 1 to 2 weeks after healing, and you're going to have abrupt onset erythematous macular rash, diffuse macular pollen cells. Good. And then diagnosis here is that you're going to do it based on the presentation, right? Of the fever presentation, right? And the culture negative. Then you're going to have hypotensive, skin changes, hypotensive, and skin changes, hypotensive, then skin changes, right? In the moment of 3 or more immune systems. Good. Now, treatment for this one is that you need to have immediate IV fluids, right? You want to look in the vagina to see if there's any obstructing things. And then you have a bunch of treatments for this one. Now, you're always going to use clindamycin because it's going to have its antitoxin effect, right? And then, so if you can methicillin susceptible, you need clindamycin. And then, if it's still resistant, you need vancomycin or linezolid. So, your clindamycin plus what? Naftalin, or so empirical therapy, clindamycin, vancomycin, right? And then vancomycin is oxacillin or naftalin, right? And then the complications of your toxic syndrome can be what? I know it can be toxic 3 to 6% mortality rate. It can be from coagulopathies, right? Vascular coagulation, cardiomyopathies, right? Or some sort of respiratory syndrome. Good. 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 Okay. Now, what is this? So how do you diagnose endometriosis? So endometriosis, you're going to need a visualization, laparoscopy, plus a biopsy, right? That's going to be, and then what you're going to see here is that you're going to see your ovaries with endometriomas, which are going to be chocolate cysts, they call them, right? And also you're going to see like these, a raspberry, or like dark blue, black lesions, right? Or like, and then here you're going to have the MRIs or diagnostic are too expensive, and ultrasounds are not too. Can I differentiate between your, what the fuck? between your adenomyosis, your fibromyoma, and your adenomyosis, right? So the only thing that's going to be pathological diagnostic, right? So we said over here. So that's dark blue raspberry or powdered perseverance. Good. What are the most, so when you have ovarian torsion, actually it's going to be at the 18 weeks of gestation when the uterus passing the pelvic brim, or immediately postpartum. Whenever you have the increased uterine movement, you increase risk for ovarian torsion, right? When you have uterine involution, right? Involution, good. The best how to diagnose ovarian torsion is that you're going to do an ultrasound plus a Doppler to kind of see like the umbilical artery, and also see like the venous flow right in the umbilical. Okay, and then you can do CT scan, but you only see the torsion area, right? So here you can do a laparoscopic detorsion, or you can do, if not liable history, you can do a fracking. Okay. Detorsion and fracking, right? Good. Now, how to diagnose someone who has congenital hyperplasia? We already said this again. I just did this. And if you have salt wasting, you're going to be hypotensive. We said this, right? You're going to be hypovolemic probably. You're going to have reduced sodium, potassium. Good. Okay. Then what do we have here? So breast cancer. So stats. Breast cancer is going to be the most common occurrence in women. Second cause of death in cancer. Right. Risk factors for breast cancer. What are the risk factors for breast cancer? Okay, and then presentation of breast cancer. So you have early findings, you have later findings, right, or locally based, and then you have late findings, metastasis. Metastasis, good. Got it. And the risk factors of breast cancer include what? If you're, think BRCA1, BRCA2, that's going to be for early breast cancer, right? What else? What are the risk factors that we're going to have? It's a breast mass, right? So it's going to be, which one you want for that one? It's going to be, okay, it's going to be females, so female age, so if you're female age, about 35 years old, about 40 years old, female age, personally affects exposure, history of estrogen, right? So female age, about 40 years old, personal bout with breast cancer, family history, personal relative with the breast cancer, BRCA1, so female age, personally affects tobacco and alcohol, so alcohol and tobacco, estrogen, increased estrogen exposure, early puberty, right? Hormone replacement therapy, right? If you're gonna have full-term pregnancy, over the age of 35 years old, if you're gonna have late menarche, early menopause, right? No, late menopause, early menarche, good. And then exposure history, and the history of cystic change with cellular tibia, good. So female age, personally affects exposure history, good. Now treatment, right? So menopause, right? Contraindications to your hormone replacement therapy. What are they going to be? If you have any sort of vaginal bleeding, right? Cancers. If you have unknown or suspected breast cancer, or untreated endometrial cancer, right? If you have thermal stroke, hypertriglyceridemia, cardiovascular disease, right? Something like that. Cardiovascular disease, right? So treatment if you cannot take it. So non-hormone therapy include SSRI, serotonin reuptake inhibitors, serotonin reuptake inhibitors, and also your clonidine gabapentin to reduce hot flashes, right? You can do your topical estrogen therapy, which has contributions to treat your vaginal atrophy, right? And then you can also do your vitamin D, calcium, and bisphosphonates, right? DEXA scan, H65 and above to remove this osteoporosis from various sides. Good. Now key facts for the test over here. Good. Okay, now what happens here? So diagnosis of cervical cancer. So cervical cancer, the thing how you diagnose it. First off, you're going to do the pap smear, right? Pap smear is going to histological, then you're going to bathotic score, right? Now, bathotic, all those things you're going to see. You can have your high grade squamous intraepithelial lesion, or low grade squamous intraepithelial lesion. You can have your atypical squamous cells of undetermined significance, and then also you can have benign, right? Benign, right? And then you have invasive cancers. Good. Now you have CIN. Good. Now let's go to that. So if benign, it's going to be negative, and then if it's benign with inflammation, atypical squamous cells hyperplasia, good. And then your cervical neoplasia is going to be your low-grade squamous endothelial lesions, and invasive, good. Now you can treat. So if you have a low-grade squamous endothelial lesion, what you're going to do here is that you're going to do a pap smear every 12 months or HPV testing, and if it has 2 negative pap smear testing, you're going to do so good. Pap smear routine screening, right? And if you have you're going to have your atypical squamous cell difference, determine the co-testing, the HPV testing is the testing, right? If you're a high risk for HPV, you're going to do a colposcopy, right, which will manage the cervical examination. Rather than if you're a high grade one, you're always going to colposcopy, right? Cervical mass. Good. Now, what reduces the risk for endometrial cancer? So endometrioid is going to be your orphan deaths, right, and all that. Now, if your fertility is still wanted, you're going to do high dose progesterone. Good. Now you can have your hysterectomy, hysterectomy, postmenopausal, and if it's advanced cancer, you're going to hysterectomy plus chemotherapy. Good. Now, how to treat PCOS, right? So you're gonna have females who do not achieve fertility, females who achieve fertility with a good bit, right? That's the treatments, right? So PCOS, right? So for females who are not trying to conceive, you can do the first thing you do is you do your combined oral placentas, right? Oral placentas, and then if you have signs of maternity, then also if you have metformin, metformin, you're gonna have signs of insulin resistance or metabolic syndrome, right? And also you can also have spironolactone if you can have, which is going to be your anti-androgen if you have hyperandrogenism. Good. Plus or progesterone, right? Good. And then for patients who are trying to conceive, right? You don't want to give them organelles, so you're going to give them your selective estrogen receptor modulator, estrogen receptor blocker, which is going to be your you're going to have your letrozole, right? Plus metformin for clomiphene for going to be second line, right? Good. Thyroid stimulator, and then for like that obesity, that you can do diet and exercise, right? For hyperlipidemia and all that, diet and exercise, right? Insulin therapy, and then for your hyperandrogenism, right? You can do oral contraceptives in the first line. Second line is going to be your spironolactone or your aromatase inhibitors, right? So you can finasteride, metformin, good, tetrazoles, you're good. Now pelvic organ treatment can be for pelvic organ prolapse. It can be your supportive, it can be your PCRs, it can be surgical, right? Now supportive care is going to be diet and exercise for those who are obese, right? And also weight training exercise, right? Now a PCRs, right, can be something you put in your vagina, which can reduce the prolapse, and also it's going to be kind of surgeries and all surgery, right? Surgeries depend on what kind. If you have a vaginal, if you have a uterine prolapse, right, you need to have a this requires a hysterectomy with spatula wall suspension, and then if it's going to be anterior posterior, go for it. You have anterior posterior over the wall. It's called pour for me. Good. Now, cervicitis is going to be what is it's going to be inflammation of the cervix. It can be the cervicitis can be caused by usually Neisseria gonorrhea or Neisseria gonorrhea or Chikungunya trachomatis. Right? The screening protocol for cervicitis is that women under the age 25 years old are usually screening for Neisseria gonorrhea and trachomatis for it's going to be asymptomatic a lot of times. And understand here, you can call it infertility, then history, and then treatment and all that. So you're going to empirical therapy, you get a single dose cyclin and ceftriaxone plus 14 days of cyclin, right? Ceftriaxone, good. Then history is that you're going to have no symptoms of the disease. You're going to have cervical discharge and cervical damage. Good. Yeah, so then how can we not traumatic? So overall, good. next to this, estrogen and testosterone, right? Most commonly cause infertility, and it's going to be a reproductive females, right? How do you diagnose PCOS and what's the criteria, right? So PCOS, you're going to diagnose it based on, you have 2 to 3 symptoms based off your you're going to have PCOS, seen on ultrasounds. You're going to have your PCOS in ultrasound, right? You're going to see signs of hyperandrogenism, right? You're going to have biological signs. Also, you're going to have your oligomenorrhea. Also, you're good. And then how do you know diagnose? And then good. Good. Now what it changes? So we have fibrocystic change and fibroadenoma, right? So fibroadenoma here, fibrocystic change. So fibrocystic change here, that you're going to have it's benign lesion, right? They're both benign. And here you're going to have tenderness is going to increase during menstruation, during menopause, right? During menstruation, right? And you're going to have bilateral breast tenderness with cystic breast changes, right? With no nipple discharge. Now fibroadenoma, this can usually affect result. You're going to have pain and swelling, tenderness, and yeah. Okay, now, then it's just going to be reassurance and pain treatment, right? 30, 50 years old, less than 30 years old. Then, good. Here. Two, right? So here, what do we have here? So we have this. So bilateral breast tenderness with diffuse core like thickened breast muscle. Okay, good. Yeah, solitary, mobile, wall, circumference mass, tenderness inside. Okay, so fibrocystic change. Fibroadenoma is benign. Solitary wall, circumscribed, nodal mass. Very good. Good. Too tough. Now IUD. So what are the contraindications for IUDs, right? For progesterone or copper IUDs, it's going to be SACUs, right? And for copper, it's going to be like an allergy. So you can have allergy, it includes your Wilson's disease or an allergy, or it can be some sort of like levonorgestrel or levonorgestrel allergy, right? And then intolerance, right? Copper intolerance, like such copper intolerance, such as your allergy or your Wilson's disease, or some sort of benign or malignant liver disease, right? And then lab for this one, which includes what? If you have breast cancer, for progesterone allergy, breast cancer. If you have levonorgestrel allergy or acute liver infection, right? SACUs incurred what? It's going to be because severe uterine abnormalities such as septate or bicoordinate uterus, right? If you have some sort of active pelvic infection, gynecological infection, past 3 months, known or suspected, known, and then what else do you have? Unknown, undetermined, unknown reason for vaginal cervical bleeding. If you have some sort of severe gynecological malignancy, or if you have some sort of active, and also not breast cancer. Good. No obstructive pregnancy, right? SACUs. So you've had it in the past 3 months. How do you feel bleeding? Very good. So you're just wondering about your energy, yeah? Good. So yeah, good. So it's gonna be SACUs, right? So your abnormalities. You're active or active gynecological infection. 3 months. No suspected pregnancy. Undetermined and study, right? And then you're gonna have so you're just wondering. Good. Now vulva is gonna be criticized for the external genitalia, right? The external genitalia, right? Problems with it. Risk factors for vulvar cancer includes dolls, diabetes, obesity, Lynch sclerosis, right? That's one. Have PV16, 18, 31. Have Hicks. It's going to be your high risk sexual behaviors, immune suppression, cardiovascular disease, right? And smoking. Good. Now, vulvar intraceptive neoplasia. Now, when you look at this, what you see is you're going to have poop pop, you're going to have ulcerations, pruritus, right, and pain. And really you're going to see is pigmented white nodules, and then you have cauliflower like this. It's going to be cauliflower like nodules, right? They can discharge. Good. Now, how to diagnose endometrial carcinoma. So first thing you want to do here is that if you're going to be premenopausal, you're going to have examination plus beta HCG exam to do that pregnancy, right? And then if you're going to be And then you're gonna have to do a transvaginal ultrasound. And now for postmenopausal here, we're gonna do you're gonna measure endometrial stripe. It's less than 4 centimeters. You probably don't have endometrial carcinoma, right? But what you're looking for is hypertrophy, hypertrophy thickening, dilation of the endometrium. Good. And then okay, good. And then look at the image you can see. And then finally, you're going to do a neutral biopsy. So neutral biopsy, if you're postmenopausal, endometrial stripe, 4 millimeters. If you have persistent vaginal bleeding, or spotting, right? And then spotting. Good. Neutral biopsy, good. So and then we're going to do ultrasound, good. And then for your premenopausal, right? You're gonna have your endometrial biopsy if you have what? If you have persistent, you're gonna have your intramenstrual bleeding, severe bleeding, or amenorrhea. So sustained intramenstrual bleeding, menorrhagia, or amenorrhea. The workup with offense of unopposed estrogen like obesity and diabetes. Good. Now, good. Good. So postmenopausal recurrent bleeding. Now, vulvar cancer. Now, I know that you're going to do a vulvar punch lesion biopsy, right? Now, and then that's your diagnosis, right? If you have your high-grade vulvar neoplasia, you're going to do your simple vulvectomy or your skinny vulvectomy. You can do topical chemotherapy. Then invasive. You're going to do your radical vulvectomy plus with widespread lymphadenectomy. Good. Okay. Now, how did that? Okay, last one. You're going to have increased FSH. And look for testosterone, it's going to be hypothyroidism, friends that overlap because of menopause. Good. The best initial treatment is going to be your short-term hormone-driven therapy if you're symptomatic underneath 60, right? Estrogen therapy. Good. Then short-term versus long-term, right? Just understand that to reduce short-term hormone-driven therapy, estrogen, reduce all risk mortality. But if you have long-term use of hormone-driven therapy, you could use breast cancer and 10 years after, or if you have 60. Increase cardiovascular death, right? Cardiovascular disease, good. Now pelvic inflammatory disease. Pelvic inflammatory disease, PID. It's going to be inflammation of the upper vaginal tract. Right? Now risk factors, pelvic inflammatory disease and history is that so risk factors for pelvic inflammatory disease include what? Okay, then history is that you're going to have right? So upper tract, and then 1/3 times giving that sheer gonorrhea, 1/3 and then that chlamydia trachomatis, right? And then risk factors of these include what? Prior SMODs, right? So prior pelvic inflammatory disease, right? Prior STDs, smoking, SMODs, right? What else? So multiple sexual partners, right? Uterine instrumentation, prior STDs, multiple sexual partners, douching or smoking douching, good. And then history is that when you look at someone with pelvic disease, you're going to have abrupt onset of a fever. You're going to have fever, right? Fever, chills, menstrual irregularities, and lower abdominal pain, which prevents from discharge. You have cervical motion nearness and explosion nearness. And then if you have like oropharyngeal contact, you can have something known as your oropharyngeal pharyngitis. Good. Now, risk factors for pelvic organ prolapse include what? The presentation is that risk factor pelvic organ prolapse include what? If you have like make it right. So if you have like be genetic predisposition, advanced age, increasing abdominal pressure like coughing, or chronic constipation, and also you can have multiple vaginal delivery is good. The presentation here is like a feeling you're gonna have urinary incontinence, fecal incontinence, dyspareuria, right? Dyspareuria, and then also you can have like and like feeling of like vaginal protrusion in your vagina. Diagnosis here, you're gonna do patient fecal maneuver. So okay, private eye, good. Fusion, matter of being good. Good. Now, uterine right? Fibroids, right? Now, fibroids, it's going to be combined of connective tissue and smooth muscle, and these are going to be benign masses. Benign fibroids or myomas are benign masses, right? Now, what do fibroids cause? These are going to cause fertility and menorrhagia, right? And fact of fibroids is that they're sensitive to hormones. They increase during pregnancy. increase inside of pregnancy and postmenopause, decrease during postmenopause. They can lead to leiomyosarcomas, right? And what else can we say about it? And that can cause anemia, right? It can lead to anemia. Now, prevalence more common in black females than white females. Good. Now, these are going to be the back, right? So, benign pathological tract. Good. Good. Now, breast cancer. Breast cancer include what? Where you said this breast cancer is going to be. We said this. It's going to be your risk factors include females, female age presents. Female age personally affects exposure history, right? So history, I forgot to say, estrogen exposure. So estrogen, if you have increased delayed menopause or early menarche, isn't therapy estrogen good? Alcohol, tobacco, prior, so personal history with prior breast cancer, right? Cancer, age, 40 years old, and female, good. Then we'll find you have you. Good. Now, intraductal papilloma. It's going to be papillary tumor invading a single lactiferous duct. Good. Now, most common causes of what? You're going to have unilateral nipple discharge from middle-aged woman, and pregnancy years. Then you're going to have 46 years old. You're going to have unilateral nipple discharge, right? Then excision is the only curative therapy. And then if you ultrasound, if I'll find your aspiration, ultrasound, put prenatal good. Plain discharge, right? Good. Now, presentation, most common, cervical cancer, no cervix and cervix, right? So we have early signs, it's going to be vaginal bleeding, late signs are going to be pain. Got it. And then vaginal bleeding, right? Again, good. Now, screening. So here at the screen test we're going to do here for your cervical cancer. So, cervical cancer, endocervix and cervix, right? Now it's endometrial, right? Now, for your endometrial, for cervical cancer, what do you see over here? So first off, you're going to have a bloody, non-purulent, non-odorous, non-purulent discharge. Got it? And you're going to have some PICU, right? Postcoital bleeding, you're going to have instrumental bleeding, and you're going to have your cervical ulceration as well. Then with the discharge as well. Then screening is going to begin at age 21. Every 3 years, you're going to have a pap smear. Then from 21 to, from 30 to 65 years old, you can do a pap smear every 3 years. You're going to do pap smear testing, HPV testing for 5 years, pap smear every 5 years. Good. Southeast strategy, you have a history, so if you have a history, if that's before that, right? So if you have your cervical biopsy, if you have a cervical, so if you do a cervical, what's it called? If you do a cervical, so if you have a cervical intravenous type 2, so that things in your screen, you're going to stop. Good. Now, special screening, so if you have testosterone for carcinoma or some sort of HIV, maybe you can screen HIV. First, you're diagnosed, so you can do 2 pap smears. And that's that. Annual pap smear. Good. Now, breast cancer. Now, early treatment. So when you have early breast cancer, early treatment is going to be conservative breast conservation therapy plus radiation, or you can plus radiation, or you can do mastectomy plus chemotherapy. Now, but in any case, you're going to do sentinel node biopsy to check the axillary nodes, right? Now, axillary nodes are good. So you have mastectomy plus radiation depending on axillary nodes. Good. And then for later, locally advanced therapy, you're going to have your HER2 directed therapy or your neoadjuvant therapy, and which is going to inhibit the growth of the breast cancer cells, right? Breast mass, and allow for your for you to do breast cancer surgery or mastectomy, right? And the sentinel biopsy, and then you're going to do chemotherapy. Good. Now, if you're estrogen receptor positive, what kind of therapy are you going to use here? Better prognosis, you're going to use your selective estrogen receptor modulator. which is tamoxifen, which is going to be an estrogen receptor antagonist, and it's going to inhibit the growth of the breast cancer cells, right? If you're going to be HER2 positive, if you're postmenopausal, right, you use aromatase inhibitor, the perfect conversion of androgens to estrogen. Good. HER2 positive, you need HER2 directed therapy, monoclonal antibody, trastuzumab, right, which is block the HER2 receptors in the cancer cells. And if you're good. Good. Now, fibrocystic change. Fibrocystic change is going to be bilateral breast tenderness with cord-like thickness with no nipple discharge. Fibrocystic change. And here you're going to have then usually going to be tenderness worsened during menstruation, right? And then you're going to have fibroadenoma. It's going to be between 30 years old here. You're going to have pain treatment and like reassurance here. You're going to have increased size and tenderness. Size and increased tenderness during menstruation. You're going to have a single solitary mass, also mass. Fibrocystic change. Good. Fibroadenoma. Good. That's fibroadenoma. Good. Now, how many days of menstrual cycle? 28 days. Then you have 2 days. You have the ovarian cycle, the uterine cycle, right? The ovarian cycle has we're working about how you have the follicular phase, the ovulation, and luteal phase, right? And this is the ovulation and the proliferative phase, the phase. Good. Now, what phase of ovarian? Okay, good. Now, how long is the follicular phase? It's going to be 0 to 14 days. Starts with menses, ends with ovulation, and then human surge. Good. Now, you're going to have the cyclic release of gonadotropin-releasing hormone, which increases LH and FSH, right? And FSH can stimulate the development of the follicle. Stimulating hormone stimulates the follicle for growth and development of the follicle. Right? And then from there, you have the development of the late follicular phase. You have the mature grafting follicle, and growing your size, right? And from there, So you have the follicle FSH, growth of the follicle, estrogen reduction. You increase estrogen reduction, got it? Estrogen reduction, right? So you get estrogen reduction, first one. So the follicle stimulates estrogen reduction, and then development of straighten. Good. Now, fat necrosis, right? No workup required. Now, fat necrosis secondary to excessive caffeine and breast trauma. Age group is that going to be 50 years old, really breast metabolic treatment is going to be, and then it's going to be fat necrosis. You're going to have benign, Yep. On the breast. It's benign, so presented radiographically like breast cancer, but on above. Years old. Good. Now, applications for okay, gotta do so. Public disease, right? Complications. Now do erope. Puffing. Well, now acute and subclinical pelvic inflammatory disease, right? Can lead to his dual pelvic, causes infertility, chronic pelvic pain, and also ectopic pregnancy. Good. And then it can be your what else can be appendicitis, which is your right lower round pain, or periumbilical pain, which is going to be umbilical pain, right? It can be your rupture of your cyst. Ovarian. Your endometrial done. I'm gonna do this shit tomorrow. Fuck. Whatever. Alright guys, it's currently 4:20. Ironic. I'm actually done studying. I hope you had a really productive night. I hope you finished everything you had to do, and join me next time, alright? I have to stay up right now and write some TikTok scripts, and hopefully they go viral. Peace out.